today's topic, which is failed cases. And I apologize to anyone who signed up a few weeks ago for this topic. I was a little under the weather, so last minute cancellation, but we'll make up for it today. So we'll just dive right into case number one. So we're going to learn quite a bit from this case here. This patient, 55-year-old male, had a lot of dentistry done, and you can see a couple gold restorations on 18, 19, and he also had a full coverage crown on tooth 17. So large arch, he has a full mouth of teeth, and gold restoration debonded. So kind of interesting to see gold restorations, seeing the prep techniques that docs have used to try to retain this. I don't think this was bonded in, so you can see those retentive grooves that were left mesial distal and on the lingual. So kind of interesting always to see that. So the plan for this patient, this was late 2020 when the patient came in with this debond. And so I'm always trying to push the limits of the material, especially the quote unquote weaker materials, just to see. So I treatment planned a CAMouflage NOW restoration. So full coverage CAMouflage, I'm trying to see how long these materials can last. So we convert the preparation to more of an all ceramic friendly type restoration or preparation. And so, which would be 1.5 millimeters of occlusal clearance from the opposing, a little heavier chamfered margin of at least 0.5 millimeter. And then rounded internal line angles. And I tried to remove most of those retentive features. And so we go ahead and bond late 2020, this CAMouflage NOW. It fits great. We use our standard CAMouflage bonding protocol of air abrasion, of the intaglio, and application of our bonding agent. In this case, we use 3M Scotch Bond Universal. And on the prep side, typically a total etch approach, so etch with phosphoric acid. I tend to use a desensitizer, certainly on vital teeth, so a gluma application of 1 minute, and then followed by another application of the Scotch Bond Universal on the prep, so scrubbing that in really well. And for the cement, we used 3M Reliax Ultimate. Well, fast forward a couple years, so February 2023, tooth number 18 developed an infection unrelated to 17. You can see our CAMouflage a little less shiny, but still holding up well. So we removed that tooth and grafted the site, planning for a future implant here. But as you can see, when this occurs, tooth 17 and the surrounding areas, when the tooth is removed, the surrounding teeth certainly receive a bit more occlusal forces. So only 2 months from that point, you can see we ended up with a failure on the lingual side of 17. And, I suspect it is due to the fact that no loading support from 18 and third molars, certainly, the farther distal we go, the greater forces these teeth receive. So that combined with maybe I didn't reduce enough adequately on the lingual side, and full coverage second and third molar situations may not be ideal long-term using CAMouflage. So it's a combination of things, and this doesn't bother me that a failure happened. This was kind of what I was seeking from that initial treatment plan. Let's see how long this restoration can last. So a little over 2 years, a little over 2 years, end of 2020, and it made it just into 2023. And so converting this preparation, so removing the old CAMouflage restoration, here's a look from the lingual, so we can kind of see the material thickness. That's close to 1 millimeter of material thickness, but with CAMouflage, what would have been more ideal is really more of a clearance of 2 millimeters. So if we could have achieved 2 millimeters, the final thickness closer to 1.5, but this is what happened. And oftentimes these types of failures, whether it's a glass ceramic or these resin ceramic hybrids, we often see failures on teeth on the non-functional side, which is the lingual side of mandibular or the buccal side of maxillary teeth, because of those more lateral forces applied to those areas. So we're going to go ahead and remove the old restoration and just clean up the preparation. I double checked the clearance with all of my Bruxer crowns. We're going to shoot for that 1.5 millimeters of clearance. If you are using a CAMouflage or an obsidian, the glass ceramic material, or even through the lab, an Emax type material, lithium disilicate, you want to shoot for 2 millimeters of occlusal clearance, because then the material thickness bumps up closer to 1.5, which is more optimal. So anytime there are fractures or these types of failures in the material, many times it is due to a lack of clearance or a lack of space provided for the material. So we clean this up, we rescan, and we go for our virtually bulletproof option, a Bruxer Now full coverage restoration. And so we go ahead and bond that in. We use a similar bonding approach. When I say similar, similar to CAMouflage. So when we bond a Bruxer crown, after try-in, we air abrade with aluminum oxide, same 50 microns as we would use on CAMouflage to roughen the intaglio. And then we need to apply an MDP base primer. So that could be something like Monobond Plus, Z Prime from Bisco. There's also universal bonding agents that contain MDP. Just make sure your whatever product you're using contains that phosphate primer or zirconia primer to create that adhesion following the air abrasion, which roughens that intaglio surface. Here's a look from the buccal, wall and occlusion, and as you can see, that tooth isolated there, living on an island. Another thing to maybe consider is for your case selection, if you want to use a CAMouflage, maybe not on a third molar or even second molar. I avoid using it on full coverage situations, but this was just something that I was trying to see how long it could last. It's hard to tell if this tooth would have continued. The previous CAMouflage crown had number 18 not been removed, but I would guess that it would have certainly lasted a bit longer if it had that continued shared support in the posterior. All right, let's see. So moving forward, we're going to place our implant at site 18. This is our Glidewell HT scan body. We placed at the time it was a Han, currently Glidewell HT 5.0 implant. And so we scan that in. This is a view from the occlusal of the implant. And if you didn't know, we do have a Bruxer Now screw retain block available. So we seat that into position. There's a good look from the buccal. The depth of the implant's pretty deep. And failure mode number 2 on the same patient. So this was, I believe, this was 3 months after the seating of the screw retain block. And the patient said that he was eating peanut M&Ms one night and felt the crown start moving. It could have happened to anything. It just so happened to be peanut M&Ms. But what happened was with these screw retain implant crowns, whether it's through the lab or now Chairside, the tie base, the titanium abutment that is connected into the implant, as you can see, the extension into the restoration, around that extension or the coronal portion of the abutment, there is material that is surrounding that abutment. So you can imagine we want to try our best to provide enough material thickness of the restoration surrounding that abutment as well. And so this is one of those situations with implants. How do we achieve that? It's not like making clearance on an opposing or rather occlusal area of a tooth preparation. We need to create enough material thickness by contouring the tissue and providing enough space so that we can expand the area of the restorative area of the design. So, going back to the occlusal portion here, this is one of those situations where I had an idea. I suspected that I would be compromising the material thickness because we did a second stage uncovery. So during the implant placement, we did a cover screw and let the tissue heal over the site. And this was a pretty deep implant. And then 4 months after we let the implant heal, we uncovered, and I used the surgical guide to just carefully uncover where that original implant placement was. And then after we get our scan, we seat a healing abutment into position to preserve the opening. So the healing abutment itself is also designed fairly narrow. So the channel that remains is fairly narrow. And I wanted to see through the design, what is the, using the most minimal space that is really allowed to create this restoration. And certainly I got my answer. So it fabricates it just fine. The system is able to create the narrow channel of material down to the base of that abutment or down to the base of the implant. And unfortunately, this is what happened. There's just so much mass of material coronal to the supporting abutment that you basically have a thin veneered zirconia area around this abutment. Now, this is bonded to the tie base very well, but material fatigue, when it's really thin material that's holding the abutment and then a large mass of coronal tooth structure above that, that's a recipe for these types of failures. So just to show you the original design on this patient, so the design software creates a really nice large contour, but you can see in the gingival portion, the area that's red, now the software is automatically adapting the gingival area to the soft tissue. And this is the narrow tissue that was left behind. And so everything that you see subgingival, that is essentially where that abutment body is. And so everything supragingival to that is really just a large mass of zirconia. So that's the thin veneer zirconia that's holding on to the abutment, which is, as we know, unfortunately, not adequate enough. So it survived 3 months, certainly not long enough. But what we ended up doing is we opened up the channel. So this is a cross section or lateral view of the block, the screw retained block. On the left-hand side is the original design, really skinny channel. In the middle is kind of the anatomy of this block itself. So you can see how that abutment or preparation, if you think about it like a tooth preparation, there is very, very little support. So how do we avoid this? It would be if you have a really deep set implant, try your best to contour the tissue to allow for a bit more of a more bulk of material that would hold on and support the restoration a bit better. The image on the right-hand side, that is not the same crown. It's a different crown on an implant that is placed not as deep as the patient that we're working on here. So more shallow implants do benefit from being able to create a better emergence profile immediately. But on deeper set implants like we have on this patient, which certainly happens with our implant restoration, sometimes it's hard to properly position the supporting bone for the implant. So in this case, we removed the old implant. And so here we use our BioLase water lace to basically remove tissue and create more of a bowl effect. So I expand it closer, just imagining the contour from the implant body itself, building that out, just kind of imagining a bowl around that implant. Looks like someone's trying to come in. I think we can let Adam in. All right, so here's a lateral view of that bowl, just kind of removing the tissue. And the point of removing the tissue is so that once we re-enter this case into the design software, we can create a much wider emergence profile from that implant. So we went ahead, this is actually after a couple weeks of an implant crown that was contoured more ideally to the modified tissue, and we can see how nicely the tissue heals around that zirconia base. So it was removed just to kind of visualize the improvement, but this is more of the healed bowl site of the soft tissue contouring. And I'm happy to say we're close to a couple years into service on this crown, and it's holding up really well. So the contours looks real similar to that original contour that we initially made, but this subgingival area is much wider to grab and support the coronal portion. And so just something to keep in mind, anytime there's fractures or failures, it usually has to do with something insufficient support or insufficient bulk of material. All right, so that was tooth 18, same patient. And here's a look at the radiographs of the difference in the contour. So initial design on the left, and then with a better emergence profile for better support and strength on the right. All right, there's a final occlusal view of our Facture NOW full coverage crown 17 and Facture screw retain crown on 19. Well, a few months later, actually it was earlier this year, this patient had a debond to 17. And so that is, out of all the failures, debonds are probably, I would say, the most common. Zirconia is just such a robust material. It typically doesn't fracture, unlike what we saw on that SRC. But as you see, even zirconia in certain situations, when it's really thin and under a lot of fatigue or stress, certainly is still susceptible to fractures. But patient still had the crown here and it debonded. Now, when there is a debond, I'm always curious to see where the remaining cement lies, whether it's on the prep or does it remain on the restoration. And so looking at the restoration, you can see how the cement actually hung on to mostly on the zirconia. When I hear of debonds of Facture crowns, more often than not, from when I inquire from the clinicians, it usually the cement remains on the prep, and it's just because the bond interface between zirconia and the cement is a bit more technique sensitive. You have to make sure it's air braided properly and the surface is extremely clean. So you're not trying the crown in again after the air abrasion, ideally, because the patient's saliva does contaminate it. But as you can see, the cement remain mostly on the crown. Now, how do we address this situation? Certainly, you can go ahead and use a burr and remove all of this old material, the old cement. But I'm always just trying to tinker and just trying to see what is the least we can do to get things back. So what does that mean? That means we're going to try and refresh or reactivate the remaining resin. So the resin is obviously, it's still hanging on to the crown. So I'm going to preserve that bonded interface and reactivate the exposed resin. So to reactivate it, what we're going to do is air braid with 50 micron aluminum oxide. That's going to help clean off any possible contaminants. You can see maybe some leakage or contaminants along the edges. So air braiding all of the remaining cement. Of course, if you air braid long enough, you could eventually start removing that old resin, which is fine. But air braiding will refresh or reactivate the remaining resin. And also we hit the areas of the exposed zirconia with the aluminum oxide as well. So that will also just refresh and just kind of roughen any exposed zirconia areas for proper bonding. But have a review of what we did. So first, on the restoration, we always try to take care of the restoration first, whether it's an initial delivery or in this case for debond following rebond. So on the restoration, we air braid the intaglio with our 50 micron aluminum oxide to reactivate the resin. I always like to rinse and dry just to remove any remaining aluminum oxide particulate that might be lingering. So we rinse and dry, and then we go ahead and apply our needed primer. So in this case, since there is resin that I left behind, I'm going to go ahead and apply our bonding agent. So in this case, we used 3M Scotch Bond Universal, but ideally you're wanting to use an MDP and a zirconia MDP containing primer. So in this case, we use 3M Scotch Bond Universal, which does include the MDP in the bond. So what happens is the exposed, we roughen the resin, it reactivates the methacrylate areas of the resin, and then the bonding agent just is infiltrated, and the MDP allows for a chemical bond to that roughened or reactivated area, and also chemically bonds to any exposed zirconia, which is that zirconia priming mechanism. And then you can go ahead and air thin the area. Bonding agents always work better when the adhesives, or excuse me, the solvents have evaporated. So carefully air thin. We like to use a little suction just to remove the excess as well. And we do light cure the area just to make sure that that bonding agent is set into position. If you want to wait, most systems are fine holding off the light cure till post-delivery. I know many are concerned about the film thickness from the bonding. It's kind of up to you. So on the preparation, so we like to get the restoration dialed in, get that cleaned up, air braided, get our bonding agent on it, and get that set. And so once the restoration is ready, now on to the preparation. So on the prep, we go ahead and etch the exposed tooth structure for 20 seconds using 37% phosphoric acid. Once that is rinsed off and lightly dried, we go ahead and apply our desensitizer. In this case, we use Gluma. I like to scrub that into any exposed dentin. And then any remaining Gluma, we want to suction or carefully dab and remove the excess. We don't want a pool of this material. So we immediately follow the desensitizer with our bonding agent, in this case, 3M Scotch Bond Universal, again, on the preparation, scrub and really well. That allows for the resin and the bonding agent to really help penetrate into any exposed and etched areas. That's what's creating that micromechanical bonding that we want, especially considering most of the debond occurred between the tooth and the cement. So the etching opens those dentinal tubules, cleans the preparation, and also then our bonding agent, we really want to help integrate it into the exposed tooth, creating hopefully a better hybrid layer, which obviously didn't form as well the first time around. And then from there, we air thin in allowing the solvents to evaporate. How do we know when they evaporate? It's really when there's little movement. Of course, when you pull the bonding agent on, you have an excess thickness of material. So I like to use a surgical suction on one end of the preparation and then blow from the opposite end of the prep. And that removes any excess, and then lightly air thin from that point. And then when you see the adhesive or bonding agent not moving quite as much, that's a good idea that most of the solvents have evaporated. And then you can go ahead and light cure. Again, that's kind of up to you. If you're concerned about that film thickness, then you can cure after the cement is seated. So we go ahead and apply a thin layer of cement. We don't overfill it because there is that original layer of resin that is also occupying the intaglio aspect of the restoration. So a real thin application of the cement and get a firm seat, and then we go ahead and lock that into position. Just want to show, so that's the final one on this patient, but the same patient on our office hours number 2, we had actually done CAMouflage veneers, no prep veneers on 7 and 10. So I know that initial fracture or failure on 217, it might make you hesitant to use the material. Yes, out of all of the permanent material options, the CAMouflage is the weakest, the lowest flexural strength. But it really just comes down to case selection. I still don't hesitate to use it for this aesthetic case, which you can see the final result here. These were A3 low translucency veneers, and it is still my go-to material for posterior partial coverage. So any posterior inlay onlay, whether it's a molar or premolar, still my go-to material. It mills so quickly, it bonds really well. The fit is fantastic. So I don't want to scare you off from using CAMouflage. It really just comes down to material selection. Looks like we have another. All right. So view from the occlusal of those veneers, they're holding up well about a year into service. All right, we're on the topic of veneers. So some of you may know this gentleman. This is Fahim, one of the sales reps on the team. For Fahim, we did 17 Facture Aesthetic Now veneers. We did them in shade bleach white, which is the lightest available shade. So just to show you the before and after intraorally. So we did 10 on the upper, we did 7 on the lower, including some posterior bridges as well. And to show you the preparations, I know some of you are interested to see this. So the preparations allowed for closure of the space that you see between 8 and 9, which bothered him. As I carried the preparation a bit more into the interproximal, usually when there's a diastamal space. That's what I try to do. And of course, if you're kind of deciding between opening space versus not, if you're kind of borderline or unsure, then it's always easier, certainly, to open that up. But you can see I don't open every single tooth. Some of the lower and mainly between 8 and 9 on the upper. But it was a good result. We did this in 2021. Started with the 10 on the upper, 7 on the lower. Well, earlier this year, again, another Debond. So 3 years into service, you can see a Debond on tooth 28. And if we take a closer look at 28, you can see it's kind of a cohesive failure. There's a failure both on, as you can see, there's resin that remains on the upper portion of the prep here. And on the veneer, the cement remain on the lower portion. So we'll get a look at the veneer in a minute. But what we go ahead and do for a debond in this situation, something to keep in mind, certainly as we rebond this into position, is we're going to evaluate the occlusion. Things can shift into position. The patient had ortho at the beginning of the veneer treatment. So as teeth move, the occlusal contacts certainly can shift into position. So at the initial delivery, maybe things weren't quite as heavy, and things do change. So here we have that cohesive failure, a little debond on the lower portion of the prep, debond on the upper portion of the veneer. And so like the previous approach, I don't remove the remaining resin. I just preserve it. I just want to see with the least amount of repair procedure, can this hold up and how long will it hold up? So I'm kind of doing my own research here. So I like to go ahead and take care of the restoration first, like the previous debond on 17. So we air braid the intaglio with 50 micron aluminum oxide. Once we air braid, we do rinse that off. I just want to get off any residue that might be lingering. We air braid the whole restoration. So we air braid the remaining resin that you see on this bottom portion. Some of it probably got removed during that initial air abrasion, which is fine for me. But the air abrasion hitting the remaining resin that stays is reactivating. It's re-exposing these methacrylate areas to hopefully allow for this new bonding interface. And once we air braid the entire restoration, we go ahead and apply our MDP containing primer. In this case, we use our Scotch Bond Universal from 3M, which does have MDP and then also has those methacrylate and resin monomers to infiltrate the roughened zirconia and the roughened exposed or reactivated resin. And then we air thin. Again, I like to use a suction, hold the suction on one end, air thin from the other, and just kind of allow for the excess to blow away, and we air thin to the point where the solvent is evaporated or the bonding agent has very minimal to no movement. And then we do like to cure that into position. And then now we set our veneer aside. Now on the tooth side, since we have resin that remains, to reactivate the resin, the ideal way is to air braid it, just like we did on the veneer. So we air braid the resin areas, and really most of the prep. We have a Chairside Danville micro etcher. If you don't have a micro etcher, this Danville unit is available through Glidewell Direct. So we use 50 micron aluminum oxide in there. We're focusing it on the resin, but it's okay to kind of get it on the prep as well. You just want to try to be careful around soft tissue. It can induce bleeding. So we apply the aluminum oxide air abrasion. It reactivates the resin. It's okay if it touches the preparation. It can clean off the preparation as well. And then we rinse and dry that area. And certainly be careful, especially if you're not using a rubber dam. This stuff does go everywhere. So certainly you're going to want to not just rinse the prep, but the aluminum oxide that makes its way virtually anywhere in the mouth. So from that point, then once we rinse and dry and really clean the patient out, now it's time to re-etch the exposed tooth structure. So to properly etch that, we're going to use our 37% phosphoric acid. So we apply that over the exposed tooth, any remaining dentin or enamel. We apply that for about 20 seconds and then rinse that off. And then we rinse, lightly dry, but one of the keys to avoid post-op sensitivity is to avoid desiccating the tooth. So I know when we etch teeth, especially for checking the bond, we're looking for that nice frosty appearance, but don't really hit the prep continuously with that air. Otherwise, it can lead to post-op sensitivity. But one of the ways we try to avoid that, and I don't have it here after number 4, is the application of our desensitizer. So we put our Gluma desensitizer, really scrub that in. That can help kind of rehydrate and reopen those potentially collapsed collagen fibers, and it can also improve upon the bonding. So we apply our Gluma. Any excess, we just go ahead and suction the excess using a thin surgical suction, and then we use our 3M Scotch Bond Universal to bond and really make sure we're getting it into the tooth. So we really focus on scrubbing it into the exposed dentin, and then also we need to reapply it onto the reactivated, the air abraded resin portion. So we scrub it into those areas, allow the resin to infiltrate into that reactivated surface, and then we air thin. And it's optional to cure, but we do go ahead and cure. This is a look after the freshly applied bonding agent layer, nice and shiny, lightly air thin, making sure there's not excess foam thickness and it's not moving. So we know that the solvents have evaporated. And then we go ahead and get our veneer, and we use the same cement that we used during the initial delivery, which is Kerr NX3. We like using light cured resin. So sometimes we'll use flowable composite as well. Light cured resins, whether it's warm composite or flowable composite or light cured aesthetic resin cements, these have been shown to be more color stable. So when you use a dual cure or self cure resin, the initiator in that sets the resin can shift shades over time. I don't know if it's all systems, but it is more common with dual cure or these self-curing cements. So something to keep in mind on all aesthetic cases, whether they're veneers or crowns, I'm using a light curable system. And you might be wondering, is it going to cure through this zirconia? Bruxer, I heard, is very, very opaque, but even Bruxer now in the posterior is still translucent enough to allow light to pass through it. If you're ever curious, you can hold your light to the restoration before you actually put it on the prep and just see the level of light that actually goes through the restoration. It's not impenetrable as a PFM would be with a metal substructure. There's translucency to all these monolithic materials and what's available with your system. So we apply our resin, thin layer of our Kerr NX3 in this case, and we seat this down. When I seat veneers, it's really important to minimize any micro movement. I like to apply pressure using these bite sticks. So I have a bite stick on the facial that I'm applying lingual pressure to, and I have a bite stick on the incisal or occlusal portion, slightly angled, so it's apical pressure. It's both apical and lingual pressure. So I'm really trying to minimize micro movement and also any movement of the veneer itself. Sometimes if you seat the veneer with the composite, the pressure from the cement, sometimes it just lifts the veneer off. So I'm trying to minimize that movement and really trying to create the most intimate interface between the veneer and the prep. So with pressure along these two areas, this exposed area in the center, what I like to do is we use a small diameter curing tip. So this is a 2x2 diameter tip. As I'm applying pressure, we go ahead and fully cure at least 5 seconds right in the center. And that helps stabilize the veneer. If we position the light tip properly away from the margins, then the margins are not set yet. So what we do is once this cures in the center, you can choose to remove the excess cement. And the fact that it's a light cured approach, you're not under this time crunch, right? The time is not ticking as to when the cement sets up. So if you want to go ahead and floss through, remove the soft resin prior to maybe even tack curing and gelling the excess cement, that's totally fine. So I tend to do that on the occlusal. So once we get the final cure here, right, again, only in the center, we use a micro brush and I just clean off the margin on the occlusal and kind of using the cement, the excess cement, just to smooth those margins and smooth that finish line. And then from there, we switch to a larger curing light, our normal size curing light, and then tack cure, really just about a second on the buccal occlusal, and we go ahead and remove the excess. So I like to remove it while it's gelled, and it's still relatively soft, but I just find it's easier. I'm not smearing the cement all over, but again, it's kind of up to you. But one of the key things I find is being able to stabilize the veneer by really almost fully curing in the center. And then the option is up to you to remove the excess. So we remove the gelled cement, and once the gel and excess, we floss through the contacts, all of that is taken care of. Then we'll use our large curing light again and final cure. And so this same approach could be used for whether you're using composite, global composite, warm composite, or an aesthetic resin cement. Okay, and I don't know if we mentioned this at the beginning, but if you have questions as we go through this, you can drop that into the chat. And if there is anything that comes up, feel free to interrupt me, Helen. We can address it as we go on. So I'm just going to check in to see if there are any questions at the moment.
No questions at this time, Dr. Shi.
All right, thank you. Okay, so another case here. Moving back to the posterior, this patient came in with a large cavitation on the mesial 31, a MOD amalgam on 30. And so we're going to try and repair this. And you can see quite a bit of wear on number 30. So the treatment plan for him is to do a MO onlay on 31 and a full cuspal coverage overlay on number 30. And for partial coverage, whether it's an overlay, full coverage overlay, sometimes they're referred to as crown lays, or an onlay, I will use CAMouflage. So we do our preparation, rounded internal line angles, trying to create enough depth, a minimal preparation for number 31, well, really for both, but a little more preparation for the full coverage aspect on 30. And then here are our CAMouflage restorations that were seated into position and bonded in. Well, a year into service, this is what happened. So fracture on the distal lingual, and anytime a failure occurs, I'm always trying to investigate what happened. And as I mentioned before, it usually is because of a lack of reduction, a lack of space created. And I always try to have, and clearly not always, but most times I try to have one of those clearance tabs. We use the ones from Kerr. It's a flex, called a flex tab, and they come in different thicknesses, 1, 1.5, and 2. As I mentioned, for CAMouflage, you want to err more on the side the 2 millimeter, but in this case, I really didn't even achieve the 1 millimeter clearance. So let's take a look at the material thickness in the zone, and you can see this is only, that first line is 1 millimeter. So I like using these probes that are a millimeter at a point. And so this is only 0.5 millimeter. What's great about this digital workflow is we can reopen the case ourselves. We reopen it and we can see this is exactly how I left the design. You can see that thin spot on that distal pit area in the central fossa. That red, anytime you're seeing that red, usually that is indicative of a material thickness violation. But I went ahead and moved forward, just trying to see, hey, let's see what happens. And certainly we already, in centric position, we had a contact on that distal lingual incline plane. And so you can see this failure happen right in that zone where we kind of have this opposing contact and where it's also thin. And what I also think happened, I'm moving back a couple spots, what I also think happened was contamination during the delivery. So you can see a little shadowing right on that distal lingual area, probably not the best bond in that spot. So a combination of factors, which one contributed to the failure? Probably all of them. So probably, but the main one being, so some things to learn, obviously isolation during the delivery, but also enough adequate preparation or reduction. So that's our design. And so we go ahead and this is a cross section of that same design, just kind of seeing, and you can see the anatomy of this cross section. If you haven't seen this before, on the left-hand side of your design, you can see this is the cross section tool. And once you activate it, you can position the cross section. Right now it's going from buccal to lingual. If you hold that green arrow here, you can drag that side to side. If you want to shift the way it's slicing through the prep and the design, you can use these blue arrows. But I was just curious, let's see exactly the thickness of that zone. And the red shell, so let me just talk about the anatomy of what we're seeing here. So the inner line is the prep. So the most inner line is the preparation. The space, so the second line is the internal of the design. The space between that is our cement spacer, which we can increase or decrease in the margin page if you haven't seen that before. But why does the cement spacer or gap increase near the middle or even change throughout the interface? And that really is due to a mixture of it's mostly due to overmilling. So the space may change because of the contour of your preparation, because the system is adjusting the gap based on the contour of your prep. So if there's any sharp areas or areas where the system needs to maybe remove more material to ensure that we get a passive seat over your prep, the system is designed to do so. So a little bit more space here. So this is why sometimes when you even prepare 1.5 millimeters of clearance, the final thickness of your restoration may not truly be close to 1.5. It's closer to 1 and sometimes even less. So what we're looking at here, based on this design that I left it, from the second line, that's the inner portion. And then this red line, this is our material thickness parameter. So it's just this is always present on every design. So if you see red through any portion of your design, it is because of a material thickness violation. The system by default will always attempt to reduce or minimize any thin areas. So it usually will generate a design to fill the space. But with these multiple unit partial coverage cases or multiple unit cases in general, I typically design with the library approach. And using library, it's kind of like deactivating the training wheels or the fail safes that are built in, and you can very easily override that minimum thickness requirements. So obviously that's what I did here. And you can even see on the margins of 31, some areas of thin there as well. So the red shell is typically 0.5 millimeter. So the system does allow down to 0.5 millimeter of thickness, even using CAMouflage in the posterior. So I'm measuring not to the red line, actually. I'm measuring from the internal portion, which if you're wondering when the cross section is on, I'm using the ruler here on the left. And I basically click on the two lines. So I click on the inner portion, the internal surface of the restoration, to the outer design, and I was less than 0.5 millimeter. So, it's one of those situations where, yeah, looking back on it, wish I prepped more, wish I maybe increased the design, but this is why it allows for me to show these cases, and hopefully you can avoid it yourself. So we re-prepped the case. So popping off the old restoration, real easy to prep away the old camouflage, trying to remove all of the remaining cement as best as I can, try to reduce a little bit more in the zone that was already under reduced. And you can see packing cord, that's a size 1 cord around, especially focused on the interproximal areas. The buccal and lingual margins are kept elevated or supergingival. And so rather than redesign it into camouflage, we went ahead and use a Bruxer material. So you can design a Bruxer now for these posterior overlays or crown lays. You have to define the design or the restoration type as a crown. Some of you may refer to this as an onlay, but if you submit the case as an onlay, the software will restrict your use of Bruxer now. So something to keep in mind if you want to do one of these overlay crown lay type restorations, define the restoration type as a crown, and that allows for Bruxer now to be used. And as far as the delivery, yes, this is a non-retentive preparation. We use the same bonding protocol that we had reviewed earlier with the veneer situation. So air braid, we like to try it in air braid. If you air braid before you try it in, you have to make sure you decontaminate the contaminated surface, because when you try it in, if any saliva touches it, you automatically contaminate the surface, which will inhibit the bond. So that's why we like to air braid after the try-in, but sometimes you might be getting these veneers or overlays from the lab, maybe, or you go ahead and air braid before. That's just kind of your protocol. Then you want to either air braid it again or use one of those decontamination cleaners, such as IvaClean from Ivaclar. There's a Zerclean, and there may be others. Sodium hypochlorite can also be used. So you want to make sure you really clean the surface to open up those, freshen up the surface of the zirconia. And then we use our MDP primer. So in this case, we use Monobond Plus from Ivaclar, which contains MDP. You want to let that sit for at least a minute. And we set that aside, and then we do total etch the prep, Gluma, and scrubbing our Scotch Bond Universal into the prep. And then we bond it in, usually in the posterior. I mentioned how in the anteriors, we use a light cured resin primarily on molars, just because of the depth of preparation. You certainly can still use a light cured approach, but in the posteriors, or certainly on molars every time if we're bonding, then I'll use a dual cured resin. Not too concerned if there is a shade shift back here. So that is the approach here. For this case, we use Reliax Ultimate at this time. Okay, so back to the anterior. This patient came in with direct composite on the incisal half of number 8. And so he didn't like the appearance of that composite, and you can see a little chip on the distal incisal of number 9. And I did a conservative restoration. So rather than a full veneer, I was really just trying to test to see, well, what is the most minimal type preparation. So I really stopped the finish line just past where the composite was applied. And then we leave the remaining enamel on the gingival half of the tooth. We settled on the CAMouflage NOW restoration. This is a CAMouflage LT. I really use LT. There's an LT and an HT, high translucency HT, low translucency LT. I tend to use LT for 99% of the cases, and the 1% of the time when I use an HT, I kind of wish I used the LT. I just find the LT has a bit more warmth to the material and just has better properties overall for most cases. And unless the tooth is, or the adjacent teeth is really gray, then that may be a situation where you use an HT, or maybe with an inlay, if you're doing an MODO or MOD, where you have natural tooth surrounding that inlay. Yeah, maybe that's a case where HT works pretty well, because then it can absorb colors from all around. But really, LT can work for virtually everything. But anyway, back to this case, we seat this down, and only a couple months into service, so look at the functional position, getting ahead of myself, a couple months into service, this is what happened. So failure on the incisal edge. And so again, when a failure happens, I try to investigate what's going on, where is the patient functioning. So we can see just right edge to edge. Usually for our aesthetic cases, we try to prescribe a night guard for the patient, but we didn't do so for this case. You know, those cases where you kind of avoid these kind of insurance, that's kind of when things come back to haunt you. But that's okay. You know, this failure happened. And see how much life we can really get out of this material. So with CAMouflage, it's very easily repairable. And the repair approach is essentially the same bonding protocol on the inside. So we resin bond this in. So we air braid the defect the same as we would the internal to prepare it for bonding. We air braid the defect and go about 2 millimeters beyond the defect with our air abrasion unit or sandblaster using 50 micron aluminum oxide. Rinse and dry. We rinse and dry any particulate or aluminum oxide that remains. And then in this case, we use our universal bonding agent, which is also Scotch Bond Universal. That's kind of our go-to. So we really scrub that in, making sure we infiltrate this into the reactivated, exposed portions of the roughened CAMouflage. We air thin and we do cure that application. And then I use flowable. So on the delivery, which I forgot to mention, the initial delivery of this veneer, partial veneer, we use 3M Filtech flowable A1, shade A1 flowable. So just wanted to mention that we use the same flowable on the incisal edge to repair it. So yes, flowable is actually technically less strong than the original, than the CAMouflage material, maybe even close to half of the strength, but that's okay. I just wanted to see, let's see what happens. So we cure it, and then we go ahead and polish the edges. We polish this, and this is after the repair. And so you can see how nice the optical properties of the flowable and how that integrates into the original CAMouflage restoration. It really has a nice blend. Let me go back here. So this restoration is holding up now. It's been in for about 3 years since the repair. So it lasted 2 months initially, and then we're at a 3-year mark post repair. We did prescribe a night guard for the patient, but you know, it's just one of those things. It's just kind of a, you know, patient catches the edge at the right angle. But what I do want to show is I'm going to go to the design, and this is the actual design as I left it for the partial veneer. So that's a good look at the preparation. This is the margin that we designed, this kind of irregular pattern to help try to minimize if we just went straight across, it increases the chances of the visible margin. So we're just trying to play with the optics here. And then we have our veneer. Now, what I want to point out is ideally, even in the anterior for CAMouflage, we want to try to create at least a millimeter of thickness, of facial to lingual thickness. So let's take our measure tool here, and we're going to measure from this facial incisal position to about this incisal lingual edge. And you can see we're right around a millimeter, which is what I mentioned we want to shoot for. But something else that caught my eye as I was kind of evaluating for this is notice how on number 9, notice how it's about the same thickness, but notice how the incisal edge is much more elevated on the lingual. The way the design occurred here on number 8, our veneer here, notice how it's much more sloped. So even though it's 1 millimeter, it's a real narrow, thin edge on the facial incisal. So what we could have done and really should have done to improve that is use one of these tools. So my go-to would probably be freeform. I'm going to try to leave that incisal edge where it is, and then basically grab I'm going to reduce this a little bit. Let me try this size. So basically grabbing this lingual incisal and elevating the position. So we're not actually thickening it facial lingually. We're bringing the lingual incisal, we're thickening it up in height, not facial lingual dimension. We're basically raising this lingual incisal position and raising this up more aligned with this, with number 9. So something that I didn't catch in the initial design, when we design anteriors, my focus is facial, getting the line angles out and the overall incisal edge position. But just an area to also consider is facial lingual dimension, at least 1 millimeter, but ideally if it's more, great. But really making sure that you have enough support on the lingual end of things for optimal strength. All right, I know we have a couple minutes left. Let me go back to this and see if we can get through another one. So the next case here in the anterior, patient came in with all ceramic veneers on 7 through 10 and came in with this fracture on number 8. So we're going to repair or replace number 8 for the patient. What type of all ceramic material? I'm not sure. This was done somewhere else, but it fractured, and so we're going to try to fix this for the patient. And so we prepare this all ceramic protocol that's about the height of the original preparation. And at the time of this procedure, this was in 2018, 2019, we only had obsidian as an anterior option. And so we mill out an obsidian CAD restoration. This is in the state right out of the mill, pre-crystallized. So this material, if you're not familiar with it, this does need to be fired, at least the original obsidian that we're seeing here. And so after firing, it does change shade. It changes to the base shade that the material was milled in. And so you can see there's a fracture kind of in the same place as the previous fracture. So we can see that in case it wasn't obvious enough. I've added our arrow here. So you can see a failure right along that mid-facial region. So, I could have left it, see how much longer it could last, but I wouldn't feel real good about that. What I suspect happened was, because of this unsupported area at the incisal half of the restoration, I think there wasn't enough support for the restoration for the overall crown. So from that point on, any anterior crowns I was doing out of obsidian, I would try to build the prep up. So I just kind of came up with this myself. My own personal rule, trying to establish 2/3 of the final restorative height. So just kind of imagining, we want to lengthen this to at least the length of number 9 for symmetry, and breaking it up into thirds. I want to have the preparation height more long to support the glass ceramic nature, which is much more prone to failure. So even though it's a really thick block of lithium silicate material or glass material at the incisal half, I just think lateral forces, just like really anywhere, anterior, posterior, lateral forces can contribute to these types of failures. So we rebuild it. So we removed the old restoration. I did a little build up, and we remilled, same obsidian. This is post-crystallized, and it's still holding up. We see the patient on his recalls, and we're beyond, we're beyond 6 years of service now. So that was just something enlightening for me. I did a similar case on a number 9 on a fracture like this, and now I make this out of Bruxer aesthetic. So the Bruxer aesthetic, would it have failed in this same case? It's much less likely, for sure, much less likely because of the greater flexural strength. It's pretty much double the flexural strength of obsidian. So If you favor glass ceramics in the anterior versus zirconia, then certainly you want to try to establish enough support for those materials. That's really one of the very important things. All the materials are great and plenty strong, but nothing is indestructible, as we've seen. So we're right at the final time. I had a few more things to show. Maybe we can do a follow-up to this part 2. But I just want to check in to see if there are any questions I can help answer.
We have one question. What shade guide are you using for matching camouflage?
A good question. What shade guide am I using for camouflage? And this is for camouflage and also all the materials. I just use the Vita Classic Shade Guide. And on that note, we did a little bit of an internal study where we compared 10 different Vita Classic Shade Guides, and we used sophisticated engineering equipment to measure the differences in shade, or really how close the shades are. And guess how many of the 10 match one another? None of them match. So it's just something to keep in mind. Those shade tabs can wear over time. So if you have a 20-year-old shade guide, maybe it's time to update it. But it's just something to keep in mind. It is they're close, they're in the ballpark, but they're not exactly the same. So I am using the Vita Classic Shade Guide for all of our cases. For all other materials beyond camouflage, so Bruxer Aesthetic, Bruxer Now in the posterior, we tend to use one shade darker. So if we're wanting A1, we'll choose an A2. But having the ability to stain is certainly a great option. I know the materials are designed to not use it or not need it, but it's just nice to have that option when necessary for those really complex cases. But my go-to is the Vita Classic Shade Guide. Thanks for the question.
What is the minimum thickness for the materials?
So the minimum thickness is about 0.5 millimeter. So you saw 0.5 millimeter for even camouflage, and it's the same for Bruxer Now. So even though the system allows for that type of minimum thickness, I would suggest in the posterior region, if you're using camouflage or obsidian, err more toward, during the preparation, 2 millimeters of occlusal clearance. That would net you material thickness closer to 1.5, maybe slightly less, because teeth don't perfectly fit together, right, in perfect planes. We have maybe 3-4 areas of contact, and from that point of contact, all else is kind of in a little bit of a space, right? We have little depressions on the occlusal or fossa. So if you shoot for 2 millimeters of clearance, the overall thickness is going to be less. For Bruxer crowns, we recommend 1.5 millimeters of clearance. So yes, it's 0.5 millimeter of less need, and then the final thickness of the restoration is going to be closer to 1, maybe even less. So software allows for 0.5, but I would recommend creating a little bit more room for optimal thickness. Good questions. All right.
Thank you, Dr. Chi. That's all the questions we had for today. Thank you, everyone, for joining us. You will be receiving a recording of today's presentation, and it will be up on Glidewell TV for you to stream as well. And we'll see you guys next time.